Hi everyone, it's Gina Pondetti Angeletti coming at you from my house during this amazing time we are in with the COVID crisis. We're talking today a little bit about wrist injuries. Specifically, I've received a ton of questions through private messenger, through Instagram, Facebook, email, phone calls, everything about wrist injuries and pain in the wrist. And I think the reason that we're getting a lot of questions is because it's pretty prevalent with gymnastics and dance from my performing arts athletes especially. But in this time that everyone's at home, we are all attempting to do more conditioning at home, more push-ups, more weight-bearing activity, using weights, gripping, and a lot of people are getting a little bit more sore than normal. I think they're also going online and doing some yoga classes and some extra things, which are amazing to do, but I think too much too soon for what your wrist can handle might be it. So today we are going to talk about wrist injuries, and we are just going to specifically address the TFCC, which is the a meniscus-like situation in your wrist that is for shock absorption and helps with weight bearing, helps with rotation, and essentially is a buffer between your ulna, which is your inside forearm bone, and your radius, which is your outside forearm bone. So it is the triangular fibrocartilage complex. Triangular fibrocartilage complex, TFCC. This is your ulna, which is on your pinky finger side when your hands are turned open. This is your radius, which is on the outside. And then, of course, you have your metacarpals and your carpal bones that everything kind of blends within your hand so that your wrist can flex and extend. It can, I'll go this way, it can ulnar deviate towards your ulna and radial deviate towards your wrist. And then it can also rotate in both directions. So if your hands are out, this is supination, like you're carrying soup, and this is pronation, P, like you're playing a piano, pronation, supination and pronation. And you can do it with your arms, and it actually comes from your shoulder, but you can do it with just your wrist to figure out what your elbow does, and that opens up. Now, in anatomical position, which is where your hands are up, your ulna and your radius sit in parallel with one another and don't cross. When we pronate, the radius actually crosses over so that when our hand, this is radius, this is ulna, and when we pronate, the radius actually ends up on the inside and the ulna on the outside relative to position. So when we are looking at this triangular fibrocartilage complex and we're trying to figure out what it is, I think everyone's questions are, well, how do I know if I have a tear there? And how do I know if that's what it is if I have pain? So, hold your hand up, and you're going to find the end of your ulna, and then you're going to find a little divot in between. And if you rest your wrist down a little bit, you'll feel that. If people go like this, they can feel a crunch. Sometimes if they flex and extend or deviate, they feel a pop or a click. And often it's because that aspect of the cartilage either has a flap tear, pizza pie tear, or something that looks like it has ground through the middle, almost like a wear spot on a baby's blanket. Very similar to what we see in knee menisci when we do surgeries and take interarticular pictures, the degeneration of the connective tissue. So it is a very complex articulation of pieces, if you will. So it is ligaments, some tendons, general scar tissue that sits in there, connective tissue, and is very, very important for everything that the wrist does. So let's go with the basics, right? So as a human being, you need to be able to grip. When you grip, you actually create a compressive force between your ulna, you're in your DRUJ, your Distal Radio Ulnar Joint, if you will. We need to be able to hold something and twist it back and forth, tennis players, etc. But we also need to be able to weight bear. And when you're weight bearing, if you put your hand down on the ground, that's a 90-degree angle, no matter how you look at it. So whether your hand, if you hold your hand up and you can only get to 40 or 50 degrees, only gets there. When you actually put your hand down on solid surface, you're going to have to get to 90 degrees. When we're talking about putting our hands down in all fours and then leaning further over, you're getting into depths of 110, 115 degrees of general wrist motion. It's not one specific joint, it's a combination of all the joints, which we'll get to at a little bit later in this program. So from a performing arts medicine perspective, and specifically, we're going to look at the two ways that this happens, right? The first way is acute, where you actually fall and hurt yourself, or you're holding somebody and they take you in a direction, or you've grabbed onto a bar after a Tkachev catch and you're not quite there, and it's pulled you into a direction that you don't want to go to. You're on pommels and you're swinging and your weight bearing is a little bit non-centered, and you actually lean on something and it takes you into a manner where you don't want to. So there's type 1, which is acute, and then type 2, which is chronic. So let's go performing arts specific, and I have some things written out just so that I don't forget when we're talking about them. So male ballet dancers, partners, those of you who are down and who are actually lifting, right? When you have a woman's weight or another male's weight on you and you're actually pushing up, the stress to that wrist is a lot. If the range of motion isn't there to begin with, that 90-degree open chain, 110, 120-degree closed chain, again, that's really hard. We're going to talk later about the shoulder flexibility and how that actually has a ton to do with taking some of the stress off of the wrist and making it so that flexibility comes more from the axillary region, your lats, your pecs, and all of your shoulder rotators, so that when you have somebody over your head, albeit cheer, figure skating, gymnastics, essentially, that's just what you're doing when you are upside down physically doing handstand. We need to make sure that we have verticality, or the term where your torso and your humerus and your forearm line up like Jenga so that nothing is actually skewed. So male ballet partners, modern dance, whether it's lifting, female, male, female, etc. Whether when you're doing modern dance, you're spending a lot of time on the floor as well, reaching, with transitions. I see it in a lot of our developmental dance kids locally that actually do dance competitions, and how a lot of their choreography is just putting their hands on the ground or slamming them on the ground. And obviously that range has to be there, or that complex is going to take a little bit of a beating. Figure skaters, right? So singles or pairs, we're talking about foosh injuries, right? FOOSH, which means fall on outstretched hand. And when you fall down onto that, onto your hands, you could have a trauma, a hyperextension injury, a hyperextension with ulnar deviation, with a little bit of rotation that really, really causes a lot of pain and irritation. Of course, this can happen in any sport, but we're talking performing arts specific. When you're talking about figure skating pairs, we are often talking about the women when they are rising and their arms are down on their partner's hand and they are pressing their entire body weight down in gripping. You're talking about the males when they are down and they are actually having to create a stable base. And this is true for cheer, for dance, for figure skating, theater, anything that has choreography that involves two humans, no matter what you are. We're talking about gymnastics weight bearing, right? Males greater than females for certain, because of the amount of hand sports that they have, or events that they have, especially with pommels and P-bars, and P-bars specifically with that radial ulnar deviation, and pommels because you're actually rotating your entire body weight plus gravity around on one arm. And if you don't have that range of motion sitting on the pommel or on the leather, it really does hurt. Many people say that leather hurts more than pommels, obviously, because when you're on the pommel, you're in this sort of an extension. And when you're on the leather, your hand is down and you're actually rotating your body around on your hand, which can cause almost like a pivot motion. And that's what really catches that TFCC. When we're talking about cheerleading, we're talking about tumbling, as well as partnering and stunting. When we're talking general gymnastics, we're talking about group and acro. We're talking about circus arts with anybody that's holding. If you get the drift, it's all about making sure that you can handle that wrist extension. Theater, props holding and repetitive motion. So things like Les Mis, when they're holding props and they're constantly rotating back and forth. If you are in a show where you're holding a stick of some sort and you're constantly reaching and rotating over and over again, again, 8 shows a week, repetitively, sometimes for people for years, prop moving, set moving, people who are pushing sets or who are pulling things that are heavy for them often affects. And then musicians, right? We have to think about drumming and wrist rotation when you're talking about strings and you're playing guitar. You're talking about this wrist, which is constantly in supination. You're obviously ulnar and radial deviating while you're in supination. So we're talking about the hand, and when you're holding an instrument, how that ulnar and radial deviation happens, but also your strumming hand, and just think about the ulnar radial repetitive. In flute playing, clarinet, saxophone is usually pretty much in a neutral position, but you're still doing a little bit of stress. Obviously, piano, the better your technique, the less actual deviation of your hands, and the more movement that's actually coming from your arms, which is great. And of course, there's a ton more instruments that we can all kind of assume. So let's go back to a little bit about the description of the TFCC itself and diagnosing it, right? So when you are getting diagnosed by a physical therapist, it is most of the time pretty easy. You're a weight-bearing athlete. You had some sort of an acute injury. Mechanism of injury is always very important to figure out. They have pain on the pinky side, right? Not the thumb side, but the pinky side, usually right here. It hurts if you open up and you stretch that, you can push and have some pain. But if you relax it in and you really get in there, it's a super sharp pain. Often if you stabilize that ulna and you have the patient move, so that instead of moving from the forearm, they're actually trying to move their wrist on their ulna, they'll get a click or some sort of an audible that will let them know that there is an issue as well. Of course, if we go to traditional medicine and we go through diagnosis, X-ray is always going to be the first point of contact, simply because we want to see what the actual metacarpal bones, carpal bones, your radius, your ulna look like. Depending on your age, we'd like to see what your growth plates look like. Are they open? Are they closed? Are the growth plates irritated? Do we just simply have what's known as gymnast wrist, which is just irritation of the distal end plates or the growth plate region? And we would also like to check and see the length of the ulna versus the radius, which we'll talk about later when we speak of ulnar variance, okay? So x-rays is checking, alignment is checking for swelling, but really what we want to do, if we want to actually delve into ulnar variance, we might go the route of like a CT scan, which is essentially a 3D replication of your wrist. It's pretty neat. You can see the crevices, the ins and outs of what the bones look like, but really what we're looking for is the soft tissue. So what we want to do is we want to get in and get an MRI. Often because of the complexity of it and because there are so many false negatives, I would say literature review 70 to 80% of people that have wrist pain don't get their TFCCs diagnosed immediately. They go into splints for 2 to 3 weeks. They have to go back into them again once they start to delve back into their sport again, and they don't address the main issues of what might have caused it if it is indeed a type 2 or a chronic, which is the mechanics of the thoracic spine, your shoulder, neck and head positioning, ribs, abdominal control, your elbow, your wrist motion, soft tissue, etc. So we get often misdiagnosed. Once we finally get diagnosed, often people don't stay immobilized long enough, or it's a surgical situation because there is a flap or a catch tear and people don't realize that, and those don't just miraculously with fairy dust go away while you're resting. Searching online is very scary. I probably found 30 or 40 websites just when reviewing before this to warn everybody that say that simply just taking a period of rest is actually going to be helpful. Unfortunately, usually rest doesn't help the issue, especially if it's type 2. It is not going to fix things, and if you're doing the wrong things during active rest, like lifting and doing some weight-bearing strengthening, it's really going to be detrimental for you. So now that we've done the MRI, it might show irritation, but nothing conclusive. So what we can do is an MRI with contrast or an arthrogram, and when you do that, the dye actually absorbs into the fibrocartilage complex itself, and we can see if the connections are still there, or if there's an irritation on this branch of it, the branch that's in between the ulnar radius, and really delve into what we need to do to fix it. Now, let's just say that it's irritated. We're going to fix it by taking weight bearing off. We're going to potentially consider doing a cortisone injection if that is the way that your medical team is going. Of course, we don't want to put cortisone in the body unless we need to, but if you're taking Advil for your whole system, it's not going to go right to where we need it. And of course, you don't really need it everywhere. So sometimes that direct aspect of issuing cortisone can be a good idea. We are also going to consider PRP injections, which is platelet-rich plasma, which will help with the regeneration of the tissue, bringing fresh blood into the area. And we can also do some regenerative medicine with some amniotic injections to help actually rebuild the tissue in the area. There are some people that do prolotherapy as well. Prolotherapy is where it's repetitive needle sticking with a perturbative substance so that it actually creates scar tissue. And when you're creating scar tissue in the area, it is to try and actually serve as a buffer or recreate the tissue that was supposed to be there and the strength of that tissue in the first place. So lots of different options for treatment. The one thing that is stagnant, well, there are 3 parts to this that are stagnant. Number 1, you have to be in a brace. The brace has to come from high up on the forearm all the way down to the hand. You can move your fingers, but you cannot move your wrist. You need to be able to have 6-way immobilization, which means, unfortunately, oftentimes having that thumb spica is a good idea. Otherwise, people will move their hand around too much, which in turn results in that domino effect of having it move up the chain. Number 2, no matter if it is traumatic or obviously repetitive type 2 more so, we need to make sure we look at your biomechanics. And what are we going to do for that? We have to measure pro and shoulder flexion to see how much shoulder motion you actually have. Standing shoulder flexion, we have to measure rotation of the shoulder, external and internal. If you are a gymnast that is doing reverse grip work or even German giant work, you have to make sure that your shoulder can actually get there, because here's the problem. If I can only pronate my arm to here, and if I do it from my elbow a little bit more, and that's as far as I can get, but yet when I'm upside down, I need the bar to be all the way here, there is a problem. And where that is, if you don't have that motion coming from the chain all the way from your thoracic spine to your scapula and your shoulder blades in the back, to the fact that your ribs have to be open and ready to move, we have to be able to measure that. So it's not just shoulder flexibility in its functional capacity, but breaking down into external and internal at 90, external and internal at 0, external and internal when your arm is at 180 degrees of flexion, even when it's behind 180. How much do you have if you're abducted here? Because you can do your giant changes with your hand. Sorry, I'll lean backwards a little bit when you're actually wider versus here. How many figure skating lifts allow you to hold a person here? Look at the stress that would be. Everyone wants the body and that verticality of gravity to be straight, right? That you can lean your body away so that it's going through, especially in acro when you're going on the ground and trying to stand up, or in circus with someone, but you're never holding somebody out here because obviously it doesn't make sense for center of gravity. So when we're talking about making sure we address the mechanics, it is an absolute must. Too many people go in, including occupational therapists, physical therapists who specialize in hand, but not athletes, and they will go in and they will just simply make sure that the irritation and the swelling is gone in the wrist itself, which is literally probably only 20% of the issue. We get everybody after because it keeps coming back. We have people quitting. We have people going to diving. We have people doing no-handed gymnastics because their doctors told them that they couldn't do it anymore. And there is hope. The no-handed gymnastics thing is interesting. We've done it. Event specialists, obviously you can't do bars or vault, but you can definitely do beam and floor with barely having to put your hands down and still be amazing. I mean, you do standing fulls and Arabians and punch double front dismounts, and even put your hands down one time for a round off. So we definitely can make it happen. So as far as treatment goes from a manual therapy perspective, what do we have to address? We have to address the actual glenohumeral joint, which is the top part of the humerus into the glenoid fossa. It's your shoulder, right? It does 6 motions, just like your wrist does. Abduction, adduction, flexion, extension, and then the rotation. You have to address your collarbone and make sure that your SC and your AC joint, your sternoclavicular joint, and your acromioclavicular joint are functioning. You have to address your upper thoracic spine, which we do in the Hinge Theory lecture, right? You have to be able to open up your thoracic thoracic spine to make sure that you can get that verticality down through your arm. You need to make sure that above everything else that is happening, that the more the shoulder is open, the less stress that the wrist will have, right? When we're looking at things like back handspring landings or vault Yurchenko pre-flights and how somebody is actually taking off and the amount of stress that goes through the wrist in the oddest of positions. We need to take still pictures off of videos when we're doing figure skating pairs assessments and cheer assessments and actually see. And first and foremost, you have to measure rotation, pronation, and supination of the wrist and make sure that that is something that is able to get to. And how I say that is, if you're measuring wrist extension and you have your hand out and you're saying active wrist extension to, let's say, 70 degrees, and flexion doesn't matter as much, but it's still good to do in both directions. You're measuring radial deviation and ulnar deviation. In a neutral position, you're measuring supination. Look, I can't get there. I could, if I fake it with my thumb, but I can't get there. It only goes to like 60 degrees. And pronation, you need to make sure that that is all accessible for you. And what I mean by accessible is the joints have to be there to allow you to do it. When you want to use that motion is up to you. How you want to use it is up to you, but you need to make sure that it's there. So manual therapy, physical therapy, sports medicine specific, please make sure it's with somebody trained. Tons of different techniques out there, but to name a few: Graston, ART, myofascial release, cupping, trigger point, dry needling, any sort of advanced cavitation or joint mobilization courses are incredibly important to make sure that that joint stays moving. So the muscles are here, the tendons are here, right? So we need to make sure that the entire forearm is released, just like the shins. We need to make sure that these muscles are pliable, right? That we go through and we actually do soft tissue. We get our tennis balls, we get our trigger point quad roll, baller, we get the products that squeeze the forearm and actually release the forearm musculature so that you can do the motion. You need to go in and actually take the radius and the ulna and make sure that those joints actually move in all directions. Grade 1 is the smallest of joint mobilization, all the way up to a cavitation or a grade 5 mob. So incredibly important in treatment. How long does it take? And this is, I think, the part where everyone gets sad. So last year I had a national team and a world team member, a gymnast that I was consulting on this. And we, it's a sad conversation because there really is no quick answer. It does take weeks, 6 to 8 to 12 weeks, if you are really doing what you should be doing from an injections perspective of amniotics or PRP or Prolo, and then you have to wait for the scar tissue to form. If you're doing surgery, it's a 12 to 16 week process, closer to 20 by the time if you're a high level gymnast or performer that you're actually getting back to doing things. And the reason being is if you only go for your 4 weeks and you don't fix it all the way, you are going to actually get to do 2 humps and you're going to waste all this time, a 16 to 20 week macro cycle for something that could have been fixed in the first place. So adhering to your time off is incredibly important in making sure that the time that you are spending in recovery is actually active recovery time. So what does that mean? It means no holding or gripping anything, because the gripping itself, even if the fingers in the hand don't move into that tenodesis posture, actually creates compression on the joint. We load that in at some point in time later. You can put bands around your wrists and you can work adduction and abduction work. You can do shoulder posture work. You can actually do pull aparts and chest press work. You can do pronation and protraction and retraction work. It just has to be that the resistance is coming from a cuff or a band that's placed around your wrist and not from your hand. You can do forearm-based activity, planks for days, modified planks, handstands on elbows, etc., and shoulder work, but it has to come from elbow weight bearing so that we still get that perturbative stimulation through the shoulder, and we actually keep our proprioception as opposed to just doing all open chain. Closed chain is really important. When we can reload again, it comes with gripping and making sure that we're not going to peel off the bar or let go of somebody's hand. We need to make sure when the initial injury happens to do grip strength testing with a hand dynamometer on both sides at widest point and at closest point. So we always do the spectrum of all 5 adjustables, and you want to do your opposite hand. Remember that your dominant hand will be somewhere between 5 and 25% stronger depending on how dominant that hand is, but you really just want to make sure that you have a baseline of where you want to get back to. Do you have 80 pounds of grip at level 3, or did you only have 50 to begin with and that's where you want to be? It's also important maybe once every 2 weeks or 10 days to try that again, and even if you try to squeeze and you get 15 pounds before pain, next time you might get 22 pounds before pain. One time of gently squeezing without overdoing it, just for perception of where the pain level is with the subsequent strength on the graph, is really important to test and to do as well. Okay, so let's move on to part 3, which is going to be ulnar variance. Okay, welcome back. So let's talk a little bit now about ulnar variance. So ulnar variance, right? So if you hold your hand out again, this is your ulna on the inside, the pinky side, and this is your radius. When your hand is turned, again, your ulna is under and your radius kind of comes across the top. But in anatomical position, or if you were to be standing with your palms forward, that's how it is. So if that is the end of your ulna and that is the end of your radius, here are the 2 bones. When I put my hand down, right, this is meant to be weight bared on more than this is. Your radius is meant to be more than your ulna. Your ulna has the TFCC on this medial aspect, on the ulnar aspect, so that it can allow for all of this motion of rotation with movement, whether it's choreographically or whether it's, for actual purpose. But that complex exists on this side much differently than this. Obviously on the inside, we don't just have 4 fingers. The radial side has the thumb and everything that goes along with it here, the anatomical snuff box, if you will. But this is where that TFCC is. Now, if this is the ulna and this is the radius, and we consistently have problems where things are banging into each other, the radius should be longer, as you can see, than the ulna. What happens if, and this is just a very, very short summary, and one theory is athletes who are traditionally circus athletes, gymnasts, weight-bearing athletes, etc., are traditionally putting weight on their arms and hands in 90-degree positions, or at least greater than 45, which is stressful, prior to when growth plates are closed and prior to when the length of the bones has completed in its growth, right? I mean, think about peaking of a women's gymnastics artistic, or think about men's and the amount of weight and pressure that they put on their hands. Think about when we are falling as skaters, right? We're going into an acute injury phase, and we're actually falling repetitively on a growth plate that might be open and might not like it. So you can get compression fractures, you can actually get Salter-Harris, there's all kinds of different things, but specifically for TFCC and for ulnar variance, let's talk. So what happens is when that ulna is stimulated, because the tip of it is actually touched and banged up against more with weight bearing, it actually decides to grow longer. And when that ulna is longer than the radius, things happen. As you can see, there becomes an abutment. And when things bang together, it actually grinds and tears, essentially, in a chronic level, that TFCC. It can also acutely tear that TFCC as someone is falling, or you can have a combination of both, which in many MRIs and arthrograms with the physicians that we work with, both on a national and an Olympic level, as well as locally, we see that there is a combination of both, that it might be an acute injury that actually caused the flare up, but underneath it, it looks like a ground away or a very thin piece of fabric. So what do we do? If somebody has ulnar variance, we can't take 12 weeks off and touch the radius and hope and pray that the radius will actually grow longer than the ulna. It just doesn't happen. Sometimes research will tell you that as a person grows, that radius will catch up and then overpower the ulna if we take some of that pressure off, i.e. a gymnast that quits or a skater that stops falling, or essentially, doesn't do jumps or fall. I don't know how you really do that, but you don't if we were to have this fake research study done. So when you take that pressure off, and at a young enough age where there is still a growing aspect left, the radius can catch up to the ulna and essentially grow longer. But what if it doesn't? What if you are actually already an adult and you're discovering this when you're 24? What if you are an elite prodigy athlete and you need to still use your hands and you want to kind of nip it in the bud and fix it? Sometimes, let's do the picture again, they take that ulna, which is longer than the radius, and they come up and they actually cut and shorten the ulna so that that spacing is left. Now, would they do that if the TFCC was completely obliterated? Potentially not. Would they have to do the shortening as well as repair the TFCC? Yes. Do some surgeons just do the shortening and then potentially see if the TFCC repairs itself because of a lack of being compressed and irritated? Yes, I've seen it all. But in general, super important to consult many people who have done this with athletes. I've probably had 100 athletes consulted with this. I'm imagining that your typical PT, OT, chiro athletic trainer might see 2 or 3 in the course of their career. So make sure that you consult with somebody that really knows the ins and outs of the questions to ask the surgeon, getting all the views on the CT scan of the 3D reproduction and or all the different aspects of MRIs and contrast MRIs to make sure that we know if this is repairable or not, and if this is shortened, if that will actually fix the problem. It's very similar to like a labral tear in the hip. Sometimes fixing that labral tear isn't really going to be fixing the problem. Okay, so as we're talking about all these wrist injuries, please write in if you have any other questions on it, specific ramp-up programs after you have taken some time off. If you have a physical therapist or a manual therapist that you're working with that would like some guidance on all of the different techniques with cupping and trigger point dry needling and ART of the forearm and the hand, joint mobilization, we can definitely do some shared co-treats through some telehealth, some e-visits. And if you're interested in obviously coming to see us in person here, we are here for you. We can do a lot of range of motion assessment on an e-visit or over video. So if at any point in time you would like just a basic wrist injury risk assessment, we are also here to do that. So visit us at achieveorthosports.com and Neurosport Chicago, and of course MedGym LLC, which is across social media platforms with all these great videos that we're bringing to you. Please be safe, enjoy your sport. Remember that you need your hands and wrists for the rest of your life, and whether you are an adult making a living out of your hands, please take care of them. And if you are young and you think that 2 weeks off is going to fix something, please understand that you need these things for the rest of your life. So take care of yourself. Thank you. Have a great day. Now we're going to get into actually looking at some pictures so you guys can see what the wrists look like in X-ray form, as well as some anatomical structure and differences. You'll see this one, the left wrist and the right wrist. The left one is the one we're concerned about, where the alignment of that growth plate, the distal radius and ulna is a little bit too aligned as opposed to the right side, and you can see the space differential. Closer, you can actually see how horizontal those growth plates look when they're aligned. And this is the big picture. So the top is a neutral ulnar variance. The bottom is a negative, where the ulna is actually less long. And that lower right picture, the positive ulnar variance, is what we want to be focusing on. Notice how it is, the ulna is relatively longer than the radius, and that tip of the ulna is sticking to a point where it would cause impingement. Now, practically, how and why are we concerned? This is just an example of a simple plank or push-up position on hands and that 90-degree plus angle that gymnasts have to endure. Vaulting, especially with blocking, with the reaction forces that go from the equipment through the arms. We need to measure and get a baseline of where all of our kids are in open chain extension, which combines range of motion and strength of the wrist, as well as flexion, which is important to see the general mobility of the wrist using a goniometer. If you have an athlete on their hands and knees, they can put their hands down on the foam roll and drop their hands to a point of being able to watch the kinematic motion of the wrist, if the elbows bend, etc. When they then do open chain motion, you can see this is 45 to 60 degrees, and we need much more. So there's a handstand. Head is out, shoulders are flexed a bit, and you can see that the wrist is at 90 or plus of 90 degrees closed chain. Now, when we open the shoulders, you can see how a little bit of stress comes off the wrist. The fingertips are a little bit less curled, albeit less stress on that distal radial ulnar joint. Essentially a perfect handstand position. Shoulders are open, wrists are at 90 or less. Horizontally, taking a look at this picture purposefully, the flexion in the hip and the break in the shoulder angle and the stress that there is on the wrists. When she fixes this handstand into verticality, you can now see that vertical line is almost at 90. Again, perfect handstand position and the stress on the wrists at that 90-degree position. Vaulting is one of the hardest things on the wrists of an artistic gymnast. You can see the impact angle depending on how the skill is that they're wanting to do. Men's gymnastics especially, a great angle upwards of 130 degrees. In men's gymnastics, weight bearing on one arm is very popular, including on pommels, especially down on the horse and not on the actual pommel itself. Sam and you will show good examples of this and the stress that goes through that wrist. Braces can be worn to alleviate and disperse some of that pressure. Now, when evaluating an athlete and looking at their range of motion, it's important to look and see the rest of the motion and their function. This is a really good picture of 1, 2, 3, and 4 of a back handspring and how a girl that has a lack of spine flexibility and some shoulder flexibility problems is actually struggling with a great amount of wrist pain and repetitive stress injuries to the wrist because of all of the impact stress that goes through the hands and elbows and shoulders. In picture 1, you can see how she's open when she hits in a relatively vertical manner. The back wrist is always taking a bit more of the stress. When she then, because of a lack of strength, and this is just her floor example, you can tell she collapses because of that core strength and understanding of shoulder opening. When she takes that to beam, you can see how when those shoulders collapse, where her head position is, the amount of center of gravity that is actually to the left, right? Or making that back wrist bend to 110 to 120 degrees. This is the best example, and you look at the spine position, and when you see that spine position, you can see the break. Now, when we talk about how hinge theory, and there are lectures on this as well, feeds into wrist and elbow. You see the 112 degree staunch angle, but then the shoulders aren't open at all. You see how when someone goes into a back handspring, how it's 144 degrees as 180 is a straight line. When you're looking again at the ground, even though this athlete has the ability to have her wrists greater than 90 degrees, some don't. And when function leads them to need it, see how that girl's hand is actually lifted off of the mat, you won't be able to actually have as much flexibility when you tell them to keep their hands down, which is what will happen in plyometric activity, and then you see the stress on that ulnar side of the wrist. Here you see the great bend at her back, the lack of shoulder opening, and the hand again coming up off the ground, that hinging at the back. Once again, another look at her hand coming off the ground. Now we look at men's and women's gymnastics as we transition into a view of hands on bars. In a neutral grip position, there is obviously stress, but since the hand is gripping the bar, it's not at 90. You then go to men's gymnastics where pirouetting skills are so popular and the stress to that wrist is great. And then the greatest bar workers in the world in both a front giant grip and essentially an ego grip also have so much irritation and stress that can happen from the shoulders and at the wrist. The amount of shoulder flexibility that is required, as you can see in this transitional handstand on bars, is great. We can look a little bit at the hinge theory example again, where we really want there to be an open orange line instead of that hinged orange line at the spine. And the more and the greater the shoulders are open, the greater the chance that there is less stress on the spine, the elbows, and the wrists. This is just a quick snippet from the Hinge Theory lecture on pinpoint pain, as well as a little bit more of an open arch leading again to that alignment. In prone assessment of the athlete, you want to make sure that the shoulders go into strength assessment as well as flexibility. When they're in a prone position, this is a before and after stretching. When they're in a prone position, you want to see how much they're able to lift. Technically, they should be able to lift to well past 180 degrees. This is a good example. If you can see, it's about 150, where she's, although flat to the ground, not to her torso. So in taking a picture of an athlete into external rotation, you really, 18 degrees negative means we're not even to that 90 degree, which is neutral. We want greater than that, or 110, 20 degrees plus. We can also evaluate their internal rotation in a neutral position, and this allows the athletes to be able to pivot on one arm. In an open chain perspective, when your arm is overhead, you can grab an object and simply just twist that object internal and twist that object external. And as you do so, you can see as when there's no closed chain torque provided, where exactly the athletes can get on their own, and the quality of the elbow and how much that's moving. And as you can see, how much that wrist is still actually being torqued as you're looking from the top. So I hope that these pictures have helped to make your understanding of how the athletes actually incorporate their spine, their shoulders, and their elbows in the biomechanics, the eccentric flexibility or the load flexibility that is needed in lengthening, as well as the eccentric strength that is needed in things like blocking and handsprings. We delve into a little bit more of the concept of verticality in the handstand presentation, and obviously the Hinge Theory speech that has been posted is a good place to start, as well as this is all interconnected. Best in health, and thanks for listening.